Fibrin is nasty. Okay, I move on to my topic of chorioretinal biopsies. Believe me, doing the biopsy is the easiest thing. The more difficult is to learn when to do and what is the indication and how good your lab is where you are sending. So when and why, as I said, is the most important thing. If you cannot establish the diagnosis, our disease is progressing and going to be blinding despite treatment, or you are suspecting malignancy. Always weigh down the pros and cons of doing vitreous or chorioretinal biopsy and how. I will show you two cases of each. So this is a lady, a 60-year-old lady who comes to us. She says there has been cloudiness in her vision. You look at the fundus, nothing dramatic, but she has few vitreous cells which appear larger than WBCs. So you know something is not right, but you are not seeing any yellowish lesions. And this was the left eye, which essentially appears normal. So we do autofluorescence, we do see something which could be passed on as a normal, but if you really want to see, there were one or two dark spots there. But to be very honest, we did not know what it was, and something going on at the level of the RPE, but nothing you could say with surety what it is. Fluorescein 2 was essentially normal unless you look back and see there were few changes going on there. I suspected the first thing was intraocular lymphoma, so got a neuroconsult, negative, MRI normal. Patient has a daughter who's a top-notch neurologist in US. She thought I was mad looking at the mom and saying it could be lymphoma. So like usual, they consulted a lot of people and they said, no vitreous biopsy at this stage, and I respected the decision because the vision was very good. But in uveitis, always don't lose the patient to follow-up. So you tell the patient, okay, come back, and if there is any worsening, you come back earlier. Within 3 months, she develops headaches, slurred speech, generalized paresis, and she has something happening in the midbrain. As usual, if you are a doctor and it is your parent or a family member involved, you don't want to believe the worst. So the daughter kept on saying that these are ischemic thing. I have consulted people here and there. I said, okay, if you say so. But her symptoms were not, very improving or anyways. So she gets a neurology consult from everybody, and they had a possibility of ischemic, and since we were insisting, they also put a rider that lymphoma cannot be ruled out. So they did the CSF analysis, which was normal, no malignant cell. However, I did get some CSF and just did a very simple IL-6, IL-10 ratio. That shows a very significant elevation of IL-10. IL-6 is the marker for inflammation and 10 is the marker for lymphoma. So, these are commercially available kits. Whenever in doubt, look for these. So this is the time now they agree for the vitrectomy, and because the choice was between doing something in the CSF and vitrectomy, so this was the time, they started believing in us and vitrectomy. Vitrectomy is nothing major, it's like simple. I'm just going to give you a couple of tips. Run the air first, like I showed in the infusion cannula, no infusion, because you would want an undiluted vitreous and without the globe collapsing. So you look at this, the normal tendency of all our vitreoretinal surgeon is to go where you are seeing the membranes, and we believe that would be the best sample. No, that's not going to be the best sample, because if you know your basic physiology, the lymphoma cells are non-adherent, so they will move away from the sheets, and these are the sheets which are going to have the usual inflammatory debris. So take the samples from both inflammatory as well as from where you are not seeing the membranes, because that is what might give you a good yield. So this is, the usual is they will show you no, but you keep on insisting, and a single cell clinch the diagnosis of lymphoma. So not only her, you can see her life also, and this is how she starts getting treatment both for neurology and for us. This is at 3 months with methotrexate intravitreal. Now coming to when do you go into choroid. The choroid is if you are seeing something in choroid, or your vitreous is not showing anything, or the vitreous is negative. Now this is an example of a patient who has undergone vitreous biopsies which were negative, and you see these here. These are the subretinal yellow deposits, which are very, very classical again for primary vitreoretinal lymphoma. And you look at the OCT, you see these bumps. These bumps, mixed autofluorescence, and those yellow deposits, they are kind of very much indicative of lymphoma. So again, before you jump onto this vitreous is very precious. Keep your labs ready, like my fellows are ready, changed, and run to the lab in the cold chain once this sample comes. Don't send it to somebody who's used to of treating your samples like routine urine and stools. So you have to have an ocular cytologist, ocular pathologist who can deal with it. And you have already seen these pictures by Sangeet. So surgery is, the simplest of the tasks. So you have to have bimanuality if you want to take the sample. So you put in chandelier, you do a good diathermy because you want your choroid not to bleed. For two reasons. One is the bleeding, and second is you want a clean sample for your cytologist or for your histopathologist. You don't want them to say blood cells seen, and they're very capable of doing it. So use bimanual, remove the choroid as well as the retina along with it. There are techniques I'm not going to do into. I sometimes use a 27G through 25, but when you are doing such a large, it's a very precious sample, so don't get into all this. Just enlarge the sclerotomy, take it out nicely, trying minimal distortion of the choroid or the retina. In this case, you can see that choroid tissue has been obtained, and then the usual fluid gas, and the retina was actually held up there in sclerotomy. So always examine the tissue when you have it with you. What have you got? Because it's a small tissue. If you lose it, the pathologist is never going to give you anything. So make sure that you have both the things in place. This is the histopathology, and this again the lady had a diagnosis of primary intraocular lymphoma. Technique is not difficult, but make sure you have hypotension kind of, and if your patient is under GA, it has to be hypotensive anesthesia. Your bottle height should go up when you are doing the biopsy, but when you are taking it out, the bottle height has to be low. The usual precautions which I don't have to take in the elite group, but again at the end I would like to say, simply because you can do something, don't go for it. Go for it if your plan is definitive and if your lab is competent. Thank you very much.
Vishali, great talk.
Thank
Just
you.
one regarding the technique. They say that you, before the final removal, before you grasp it with the tissue, and do you usually grasp the edges with the forceps?
Edges.
And you, before the final cutting, you keep one end attached before you finally make the cut. After grasping it, then you make that
like
cut.
a pedicle, so you have to go along it. Yes.
So do you detach the retina over it, or
No.
Chorio retina is combined?
Actually, you gave me the topic. That's why I presented. These days, I don't even do it, because through the integrated microscope, you can actually see where the subretinal deposits are. So you just make a small little retinotomy on top of subretinal deposit. You put your fluid, get it aspirated. The subretinal deposits themselves are very good for making the diagnosis most of the time. You really do not need a choroidal biopsy unless for tumors, and I don't do tumors. So for me, I don't do it as a routine, you know.
I know